Now let's talk about a new way of thinking, how to cure periodontal disease rather than just control it. The first thing in this concept is we need to understand the difference between an infection and inflammation. An infection is caused by an irritant such as bacteria, calculus, overhanging restoration, and so forth. It has to have an irritant. Inflammation is the body's response to an irritant. To summarize that, infection is the cause and inflammation is the body's response. Inflammation is a double-edged sword. It is necessary for healing and it also causes tissue destruction. For instance, if we slap our hand and it turns red, that is a necessary response for healing. By the same token, bacteria cause tissue destruction, the other edge of that double-edged sword. There are three basic inflammatory diseases that we're concerned with. Certainly, as dentists, periodontal diseases are a major concern, but we're also concerned with cardiovascular disease as well as diabetes mellitus. Chronic adult periodontitis is a bacterially induced chronic inflammatory disease. It destroys connective tissue and bone that support the teeth. Now let's talk about plaque and how it develops and so forth. First of all, we're going to talk about the term the acquired pellicle. This is a thin protein-containing film derived from salivary glycoproteins. If it's removed, it begins to reform in 30 seconds after brushing. How do we remove bacterial plaque? First of all, brushing and flossing, and also coming back into vogue is the use of dental water jets. And here's an article pointing out that moderate hydraulic forces produced by a dental water jet can significantly reduce the biofilm, the acquired pellicle, and if you reduce that, the bacteria are reduced as well. For many years, we poo-pooed the idea, but the idea of using water jets is becoming back, and the most popular one is the water pick, which costs about $60. Cardiovascular disease risk factors or the irritants in that. There's smoking, high blood pressure, and high cholesterol levels. These are all the risk factors, but also the irritants that lead to cardiovascular disease. What is cardiovascular disease? It means there's lipid accumulation, coronary vessel plaque, and there are multiple inflammatory biomarkers, including an elevated C-reactive protein, and cardiovascular disease, plaque accumulation, is present for many years before significant plaque accumulation is found. Let's talk about diabetes type 1. It is caused by an autoimmune destruction of the pancreatic cells of Langerhans. Number 2, T cells play a primary role. Type 2 diabetes, by contrast, is caused by insulin resistance and the body's attempt to create additional insulin. Ultimately, this results in a burnout of the insulin-forming cells. Why is type 2 diabetes an inflammatory disease? Because it has risk factors which include obesity, especially belly fat. So look at the word belly fat. The fat cells can produce chemicals, lipoproteins, that are associated with inflammation. Thus, type 2 diabetes is an inflammatory disease. How does this relate to periodontal disease? This is a comprehensive report issued by the American Academy of Periodontology in 2011. Survival in health is characterized by the absence of inflammation, which may be clinically associated with redness, suppuration, and bleeding on probing. Understanding how inflammation works. Lipid mediators control the magnitude and duration of inflammation. They are biosensitized from omega-3 fatty acids. Now let's talk about the objectives of periodontal therapy. First of all, we want to minimize the body's inflammatory response to all irritants. Although this is impossible to eliminate all inflammation, reducing it to a level where there is no bleeding on probing or further attachment loss is our basic objective. Pocket elimination certainly should be our number one choice, but if we can't get pocket elimination, what we want to do is to convert a pocket into a periodontal defect. Now, what do we mean by converting a pocket into a periodontal defect? A periodontal defect has excessive probing depth with no bleeding on probing, no suppuration, stability over many years, crestal density. The keys to successful treatment. The patient must brush and clean interdental effectively on a daily basis. Now, cleaning interdental includes not only flossing, but perhaps using interdental brushes or other devices where indicated. They need to clean their tongue on a daily basis, and that will be discussed further on this video. Complete the recommended treatment. You're not going to be able to do anything unless the patient completes the treatment. They've got to adhere to the recommended maintenance schedule, and if the patient is diabetic, we need to control the blood sugar, and we need to stop smoking. And if you look at all of these are under the patient's control, and that's a significant factor. Let's talk about the importance of cleaning your tongue. About 90% of the bacteria left after thoroughly brushing and flossing are left on the posterior part of the tongue. These are sulfur-forming bacteria which give off the odor of rotten eggs, and most people have never cleaned back in that area. I've tried several different cleaning devices, and the one that I like best was developed by Dr. Robert Rippich, and we can see that below. There's an in-depth video on that, as I mentioned, which I would urge you to look at. The information on Dr. Rippich and ordering this is an 800 number, his website, and so forth. And those tongue scrapers, I think, cost about $7. Why smoking cessation is important. 2 patients with generalized periodontitis. The patient who smokes has a 247% greater chance of losing their teeth compared to the non-smoker. So smoking cessation counseling is available also on the videotape, and I think this is about 6 minutes long and involves our own Bill Burgess as the simulated patient. Where does this data come from? This was a research project that we did while I was in Charleston, took about 6 years to do, and used patients from my clinical practice for our database. And this was published in the Journal of Periodontology in 2014. This is the Miller-McIntyre Periodontal Prognostic Index, but currently the cool thing to do is to brand things. So we have branded this as the MMPPI. It's evidence-based, it's statistically validated, it is accurate, it has been published in the Journal of Periodontology, and more importantly, it got the Clinical Research Award for 2015. How do you apply this in clinical practice? First of all, we've designed several score sheets. This is probably the 5th or 6th one, and each one is markedly simpler than the other. And you will notice down here on the lower right are those keys to success that we have already mentioned to reinforce that to the patient. And on the back of it, for you in clinical practice, this is a welcome comment to the patient. Welcome to our practice. As part of your complete examination today, we will provide you with a score which will accurately predict the outcome of your periodontal treatment. I won't read further on that, but this should be placed on the back of the score sheet, which can be given to the patient in the reception area to read before they ever come into the operatory. Not to bore you with statistics, but we use the Cox proportional hazard model for our statistical analysis. And you can see the statistical analysis on the 7 factors highlighted by colors to the right under the hazard ratio. You will see 3 of those are in blue. meaning they are not very significant. And you see the one in red, smoking, is the most significant. But what I would like for you to look at, furcation involvement, is circled in blue. And what, for the first time, we now have scientific evidence, statistically evaluated, that simply because a tooth has a furcation involvement does not mean that it has a poor prognosis. Do mouthwashes play an important role? And the answer is yes. And I would suggest that you go to this video for more information on that and look at the most effective and least expensive mouthwash that you can use. And using this mouthwash in conjunction with the other information that I am giving you are markedly going to cut down on the bacteria in the mouth, adding to the concept of curing periodontal disease. Now let's talk about the treatment to cure periodontal disease. First of all, you need to explain the treatment concept to the patient and let the patient know what their commitment must be, and that's the keys to success. Second, you need to score the patient using the MMPPI to motivate the patient to fulfill the commitment to cure their disease. And finally, you've got to provide some type of preliminary smoking cessation counseling on all smokers. Now let's talk about the clinical application of the MMPPI. There are 7 factors that comprise this: age, smoking, diabetes, molar type, probing depth, furcation involvement, mobility, and a total score. The first 3 factors, age, smoking, and diabetes, can be taken from the patient history before they even start the clinical exam. And an interesting finding on age. Before doing this study, I thought young patients with severe disease necessarily had a poor prognosis because we could only try to control the disease. But what we found in this study, which took place over patients seen over a 40-year period of time, those younger patients that accepted the commitment to what we did actually had a better prognosis than older patients. So therefore, if the patient is under 40, they score a 0. If they're over 40, we score a 1. To determine the diabetes score, we use A1C levels. And you can see those scores down there. And certainly we want to keep the score below an 8. For over 8 is when we begin to see the changes that are so detrimentally seen in diabetes. And smoking, because the score was a 3.46 on our statistical model, we use a score of a 4 for smokers. Factors taken from a clinical examination. The molar type, and certainly on any clinical exam, you're going to do probing depth, furcation involvement, and mobility. Initially, we did not plan to score molar type, but when the statistician evaluated this, she found such a discrepancy between maxillary second molars and mandibular molars that she indicated that we needed to have a scoring system. For those of us that have been treating cases for many, many years, we all know that the maxillary second molar has the poorest prognosis of any molar in the mouth. The maxillary first molar has a better prognosis than the second molar, and the mandibular molars have a better prognosis than the maxillary molars. Hence we score them mandibular 0, maxillary first 1, maxillary second a 2. Probing depths. Anything less than a 5 really does not impact prognosis. If it's a 5 to 7 millimeter pocket, we score it a 1, 8 to 10 a 2, and over 10 a 3. Now, on furcation involvement, this is extremely important that you understand this. The study that I did was a retrospective study. So therefore, in doing the exam, I only indicated where a furcation was involved, not where it was a class 1 or class 2 or class 3. So this is based on the number of furcations involved, not the degree of severity. If they have no furcations, that's a 0. If they have 1, it's a 1. If they have 2, it's a 2. And on a maxillary molar, if you have 3, it's a 3. Well, certainly you cannot have 3 furcations on a lower molar, so if you have a through and through furcation, you score that a 3. Mobility, as you'll see on the in-depth video, was based on our clinical impression. One, mobility means that I'm aware that the tooth is mobile, but I don't think it's impacting mobility. 2 degree means I think I'm concerned about mobility. And 3 is I'm really concerned and the tooth is possibly a hopeless tooth. So now let's score 3 different patients. The first patient is, we're going to score the age is a 1 because the patient is a 42-year-old male. And let me tell you, this is the typical patient that I saw in my practice over 40 years. Second, the patient was a smoker, so we score a 4. The patient is not diabetic. So as I said earlier, these scores can be taken from the case history, and I like to think in terms of a treatment-focused diagnosis. And this patient would be diagnosed as a moderate to severe localized periodontitis in the molar areas. Now let's talk about what that means. A moderate to severe moderate to severe periodontitis, we're going to treat with initial preparation and root planing on that. We will see the result and we may or may not do surgery. But by adding to that in the molar areas, we can see that the rest of the mouth probably is healthy or just simply needs a prophy because the patient does not have attachment loss in those areas. So there the patient is a 5 before we ever start doing the clinical exam. Now the clinical exam, as we pointed out earlier, involves the molar type, probing depth, furcation involvement, and mobility. So we're scoring tooth number 15, and that scores a 2. The probing depth is 2, generally 5 to 7 millimeter pockets, but an occasional 8 millimeter pocket. There are 2 furcation involvements, mesiopalatal and distopalatal. And yes, I'm a little concerned about the mobility because we're dealing with a 42-year-old patient, and that would be a score of a 13. Well, now what does a 13 mean? It's off the chart. And in most practices, because it's off the chart, the prognosis is less than 50%. In all probability, that tooth would be condemned. But then we need to go ahead and work on what I refer to as a periodontal scorecard and give at the initial exam the patient the target that they need to aim for. So let's give them the target score, which will be given at the first appointment, and treatment will be geared to see if we can get this treatment score. Age is not going to change. The patient stopped smoking. The patient is not diabetic. Molar type remains the same. Probing depth, we don't get an ideal result on this. We still have some residual 5 millimeter pockets, which over time we may be to reduce even further. And on furcation involvements, can't do anything about that. But the mobility is now being reduced, although we have some, and I feel a whole heck of a lot better about it. The score is now a 7. So from a hopeless prognosis, we can now offer this patient a 15-year prognosis on this case of 86%. I think you can now begin to see how motivational this can be. Now let's look at patient number 2. And this is where we as dentists become the doctors of the mouth. And this is a patient you general practitioners are going to see often in your practice. We're dealing with patient number 2, who is a 29-year-old female. So therefore, that is a dash. It's on tooth number 14. This patient is smoking 2 packs of cigarettes a day. We put a 4 on that. And the patient says that she's not diabetic. But let's look a little deeper. Our treatment-focused diagnosis is a severe generalized gingivitis, which means that we are not planning on doing any periodontal surgery, but because of the severe gingivitis, as the tissue heals, it may be very fibrotic, and we may want to do a little gingiplasty to get the thin knife-edge margins we would like to see. But now we see the importance of a treatment-focused diagnosis. Significant findings from the patient history. The mother and 3 aunts are diabetic. So there's a strong family history, and it is on a gender-sensitive situation. The patient is significantly overweight. So now we're getting the idea that we may be dealing with a diabetic patient. But the patient denies being diabetic, So I would suggest doing an in-office A1C score. For if you refer the patient to the physician, it's probably going to be 6 weeks to 2 months before you get the patient back. And by that time, the impact of the significance of treatment may have waned, and the patient is not interested in getting started with treatment. So I would suggest doing an in-office A1C, which you see on the right. This can be ordered online, and by ordering it in a box with 10 in it, the cost of doing this is about $12 to $13 per test. And on this patient, the A1C turned out to be an 8.7, which is certainly a well elevated blood sugar, and the patient, in all probability, would have a diagnosis of diabetes mellitus. But a word of caution on this: that is a medical diagnosis, and we never need to brand a patient as diabetic, for this can have an impact on their work. Perhaps they're working on a skyscraper, and when they find out they're diabetic, they may possibly lose their job. So please, please do not tell the patient when you have an elevated blood sugar that they have diabetes. Simply say, this test indicates that you have an elevated blood sugar. You need to see your physician to see if you have diabetes. Now, we've scored the patient, and the patient now is diabetic, and even though they're young and not smoking, they have a score of a 7, which is a very significant score. We're dealing with tooth number 14. That's 1. The probing depths are around 5 millimeters, but remember, this is because the patient has a severe generalized gingivitis, and the tissues are very much hemorrhagic and enlarged. And certainly one thing you ought to take into consideration on this patient: getting this patient in and doing 6 probing depths on each tooth with a severe gingivitis is only going to accomplish one thing, and that is the patient ain't never coming back. So therefore, perhaps you need to guesstimate at what the probing depths are, perhaps very lightly and gingerly probing a tooth or two to kind of get a feel for the mouth. Obviously, there are no furcation involvements, being in a gingivitis case, and because the patient is diabetic, we see there's increased mobility in the diabetic patient, and although we have a gingivitis, look at the score on this patient. She barely has a 50% chance of keeping her teeth for 15 years. So let's go in there and give her a target to aim for on this. Age remains the same. We're going to encourage her to stop smoking and to get her diabetes under control. And if we see this is not ideal, we're making improvement toward that. Molar type remains the same, and certainly we're going to get rid of the pockets on that. There are no furcations, and I would think by reducing the inflammation and getting health, the mobility is not going to be as impactful. And looky here, you've taken the patient down to a 3, a 96%. So therefore, when you give patients this positive of target to aim for, it goes without saying the patient is going to be more motivated to accept treatment, probably is going to complete treatment, and probably become a good recall maintenance patient. So we're going to go from an 11, which is a 53% chance, to a 96% chance. Now let's go to a more challenging patient. Patient number 3, who's a 75-year-old male, who's a non-smoker, that says he's diabetic, but does not know his A1C score, and initially does not want to have an A1C done in the office. What do you do on that? Well, if the A1C score is not known until you get an A1C score, use a score of a 2. The treatment-focused diagnosis is a moderate to severe generalized periodontitis. This is a patient probably that would benefit from periodontal surgery, but as you're going to see in the moment, may just opt for some initial therapy on that, which could be quite impactful. So now let's score our 75-year-old patient. That scores a 1. The patient is not a smoker. And on diabetes, since we don't have an A1C, we're going to score a 2. Number 14, molar type, is a 1. Probing depths are generally greater than 7, so therefore we're talking in terms of a 2. And And on the tooth number 14, we scored 1 furcation, and we have some mobility, but the fact that the patient is 75, I'm not as impacted about the mobility as I would be on a younger patient. If this patient were, say, 30, I would probably score the mobility a 2. But in any event, this patient scores an 8, and this is where the problem comes in. For when we look over here, the patient has an 81% chance of keeping the teeth for 15 years. So therefore, I think convincing this patient to have surgery to get pocket elimination is going to be a tough sale. But I think we can give him a target, and let's see what perhaps we can accomplish with non-surgical treatment. Age is going to remain the same. Smoking is negative. And we do an A1C, and it comes back about a 6.2, so he's better off than what we thought. The molar type is a 1. The probing depth, we're not going to get total pocket elimination on 7 and 8 millimeter pockets, but if we go in there, typically I think depending on the level of hemorrhagic tissue, if you've got very hemorrhagic tissue, you can probably reduce these pockets 3 millimeters, and if you have non-hemorrhagic tissue, then you're only going to reduce them by maybe 2 millimeters. But by taking an 8 millimeter pocket and reducing it by 3, you get it down to a 5. So therefore, the probing depth becomes a 1. We still have that furcation involvement. And once the patient has the initial therapy and looks better, then I'm really not going to be concerned about the mobility. And all of a sudden, he can come down to a 5 or a 93% chance. And if he uses the tongue scraper and has a more pleasant smelling breath, and his mouth feels better, we have really done a super job on him. And therefore, we have come up with this little ditty, and I think you'll get a kick out of this. If you want to keep your teeth alive, keep your MMPPI below a 5. And that's what we're striving for in this 75-year-old patient. The objectives of the clinical application to motivate the patient to accept and complete treatment. It can also, by giving this sheet and some blank sheets to take to them, it can create patient referrals because you are different from the average dentist and you are giving them in-depth information that is very motivational. To simplify scoring so that it requires no treatment time or chair time from the dentist, and to train the staff to do the scoring, which is being done in some offices. Is the patient guaranteed this level of success? This is not a promise of success, but a guideline that allows the patient to cure their disease. Number 2, the patient assumes 100% of the responsibility for success. For as we look to the keys to success which we've given you, all of those are under the control of the patient. And if they violate those, like not keeping maintenance appointment, that's not your fault if they fail. But if you do all the things, or they do all the things we've suggested in this video, I think they can be cured of their disease. So the dentist assumes no responsibility for the outcome. Conclusions. Scoring markedly motivates the patient to accept treatment. Number 2, is fast, simple, and easy to score. Number 3, increases referrals from patients. Proves that many teeth that we initially thought to be hopeless are in fact treatable. And very importantly, for the first time scientifically, we have proven that teeth with furcation involvement can have a good long-term prognosis. Later, we're going to talk about the difference between a periodontal pocket and a periodontal defect, which will be in another video.